In this podcast, Aaron Black from Inova Translational Medicine Institute talks about the future of data in health. So, stay tuned. Welcome everyone to Future of Data Podcast. Today we have with us Aaron Black. Aaron Black is Chief Data Officer at Inova Translational Medicine Institute. And a brief bio. So he's a healthcare information technology executive and data evangelist, result-driven technical leader with 20+ years of successful project and program implementations, visionary, collaborative, and able to devise creative solutions and culture to complex business challenges. Key thought leader, international speaker, team builder, data architect in building advanced and one-of-a-kind technical and data infrastructure to support precision medicine initiatives in large cutting-edge healthcare institutes, a featured speaker and panelist at National Conference of Council, including TEDx, NIH, Amazon reInvent, Precision Medicine World Conference, Lab Roots, HIAMSS, and an invited speaker at the National Research Council's Standing Committee on Biological and Physical Sciences in Space. Experience in startups and new team development, proven change agent in diverse organizations and political charged environments, a catalyst to create vision, motivation, result across entire enterprise. And excellent interpersonal skills, able to work effectively with individuals in diverse background and inspire team to work to their fullest potential. That's a handful. So thank you so much, Aaron, for coming to the podcast.
No, thank you for having me. I appreciate that. It's always fun to hear about yourself in verbose terms like that. So I appreciate it.
Great. And so why don't you walk us through your journey? So if your background and what brought you to this world of data science and what you do with Inova?
Yeah. So my background is I've interviewed a lot of people. It seems very similar to the paths that people take in that you get somewhere at the end where you weren't sure, how you got there, right? When I came out of school, I don't think a chief data officer was even a thing. So how we got here to Inova in Washington, D.C. is my career started out of college. So I had degrees in accounting and management information systems. So I was a business major and I was so good at it. I stayed 5 years at Miami of Ohio and have a double major. But when I got out, this was right before Y2K, so 1999, and people were all over the place with, hey, is this thing going to crash on us? Our computer's going to stop. Our stoplight's going to, Armageddon. I can still remember January 1st. People weren't sure. They had water and they had batteries. They weren't sure what was going to happen. So when I got out, my first job was really to convert people from these green screen types of systems into actually GUI interfaces. And so I came out and got my hands dirty really quickly. Really gravitated towards the data aspect of things. So I could do networking. I did desktop support, but we did a lot of programming, and I got really good at converting. So I got to see a lot of systems. Got to take them from, think of Excel, glorified Excel or Access to SQL Server, Oracle systems, and did those very rapidly because people weren't waiting. They needed to get their businesses running. So I did that for 3 or 4 years and then joined a startup in Columbus, Ohio. So I originally started in Cincinnati, Ohio. Moved up the I-71 to Columbus and worked in a startup that did medical billing. And it was the first time I got to see healthcare in its state of just disarray. So coming from one that says, hey, you want a bill and you're going to get paid for what you do. Well, healthcare was a lot different. Healthcare was, well, you're going to get paid, but it depends on who your payer is, depends who your provider is, depends on who's paying that month. Are you Medicare, Medicaid? And so I had to learn that on the fly too. But I got into converting people. So going from a system that couldn't bill to a system that could, and doing 4 or 5 of them at a time. So I began to, again, see patterns in data and seeing the ways that these systems were set up and having to navigate very quickly, bring on team members, and just do these things very quickly. Did that for 4 or 5 years and then got an opportunity at Nationwide Children's Hospital in Columbus. They had gotten a very large grant from the National Institutes of Health, and it was a project called the Cancer Genome Atlas. And at that point in time, again, being a business major, being in all these types of more business aspects of data, it was my first really look at research in biomedical informatics. When he asked me, so this is a friend of mine from where I grew up. He was the director of informatics at this research institute in the Children's Hospital. And he said, "Do you want to do this?" I said, "I don't even know what a genome is. Like, I don't, I have a high school biology background. I'm really going to have to understand what's going on here." But he said, "You have 6 months, it's you, and you had to build a team, and we're going to give you, and the bigger team, $6 million, and then you're going to recompete in 6 months. Do you want to try?" And I was at a point in my career, I said, "Okay, this sounds fun." So we got to learn that on the fly. Again, now it was applications, biobanking, and we can get into this later, what biobanking is, but think tissue trade at its very core level, but for cancer. So it was the first time, and I had like a why. Why are you doing this? Like, it was actually something very mission critical, and not that insurance and other things that I was doing was not mission critical for those industries, but now I had a reason to give back. And in 3 or 4 years, we built a team of project managers, software developers. We were Java based. We did a lot of data coordination and moving together data sets and dispersing them across the country, and really found a niche there and said, this is some place where I think I can make an impact with my skills that I had developed over those first 9 years. And that's when I moved to Inova. So then I moved my family from Columbus to Northern Virginia. So we're located 15 miles outside of Washington, D.C. The Inova health system is a community-based healthcare system. So if you have an emergency room visit in Northern Virginia, if you have a baby in Northern Virginia, 70% of the time you're coming to an Inova facility. So it's a quite large organization, but very fee-for-service. And this was this institute that I'm in, which is the Inova Translational Medicine Institute, was the first time Inova had done some research at this type of scale. And it's all around genetics and genomics. And so when I came in, they had been there had been in existence for about 2.5 years. They had a mouse. They had about a little bit under 2 petabytes of data. And this was all connected to the electronic health record. And they needed someone to come in and operationalize that, because they were, just think of loose collections of data sitting everywhere. A lot of probably people that you know and or you're interviewing have the same problem. It's data silos and things that just aren't organized in a way that can be scalable. So we came in, again, had to build a team from pretty much scratch. And now 4 years later, we're moving into even a larger facility because biomedical informatics and translational medicine and the term precision medicine is exploding. And you hear a lot about it, and our teams now have to deal with that, the expectations of what this can do. And I'm sure we can get into that as we discuss. So right now I lead a team, think full data acquisition, from acquiring data to modeling to quality control. We use systems like clouds, who are a big AWS user. We also have built local Hadoop clusters and have traditional relational databases that the healthcare system helps us manage. And we do all the support for all the analytics, all the bioinformatics, as well as clinical reporting now. So now back to the translational side, we actually do clinical reporting that can impact patients as they come through the health system. So we manage all that data across the health system.
Wow, interesting. And thank you so much, Aaron, for walking us through all the nitty-gritties of your background and what you do currently in Inova. That's really, really helpful. So what is translational medicine for our viewers and listeners? So if you can walk us through what exactly it is.
We'll resume after a short break. This part of the podcast is brought to you by First Friday Fair, fastest AI-powered way to find your next opportunity. Check out the website firstfridayfair.tao.ai and find your next dream job. Let's get back to the podcast.
Yeah, so at a very high level, it's basically taking the research that we do, and a lot of that is very data-driven, and translating that back into patient care. So how that's different than like a basic research is going in and just trying to find the fundamental understanding of something that's happening. You'll write a paper, you'll get a grant, you're just acquiring knowledge and sharing that with the community. What we're in the business of doing is taking that knowledge and actually putting that back into how we treat our patients. So a common example of that would be what we do with pharmacogenomics. And what pharmacogenomics is, it's the study of how a drug affects a particular person based on their genetics. So if you have certain genes that you will metabolize a certain drug better than others, or it won't impact you at all. So we've taken all this research that's been done across the country, across the world, and are now applying that to a person who comes in and maybe had a heart attack or has a heart condition. And there's just a bunch of drugs that may or may not work depending on their genetics. Well, we now can take some blood, or you can spit in a cup, comes to our lab, it goes through the health system. We generate a report that then can tell you, and think very simplistically, green, red, yellow. There's a lot of sophisticated analytics going on here, but doctors don't want to read all the detail. They just want to know, is this going to be effective for you? So our team helps with other vendors and translates that into something that, again, a person can understand, is that drug good for me or not? And hopefully, can save their lives or at least increase their risks or decrease their risks of having an adverse reaction to a drug.
Interesting. And how close typically are you aligned with say pharmaceutical companies and their research on, like, how closely are sort of your data gathering and analysis is shared with pharmacies?
So right now, it's very isolated. So there are some privacy concerns. There are some, just think of even, how we share data with outsiders, from a de-identification standpoint. So right now, we do not share that data directly, the genetic data directly with these pharmaceutical companies. Now, they will get data that says we dispensed something and here's what we did. And that's been going on for a long time. If you read the history of the way that the healthcare systems work with pharmaceutical companies, they have data brokers that do a lot of that. But as far as the genetics go, we keep that in-house because our consents, when we consent a patient, do not allow us to share that information. But that's a very interesting point, and things that on the, when we look at the data officer roles and things like that, we're looking at ways to, take this data and make it more valuable, not just for our internal consumers, but for others who could take that data and do good things with it. So when you start to do pharmacogenomics at scale, and you're now seeing populations come in and you're seeing it longitudinally, we do think that's a valuable asset that a pharmaceutical company would be interested in, both to improve their product as well as hopefully lessen the burden on our population of what they spend in drug costs.
Interesting. And I think you were talking about precision medicine. So what exactly is precision medicine?
So precision medicine is where you're looking at that molecular level. So you're looking at your genetics. You're looking at every cell in your body has a code that says, this is what we want the cell to do. So the precision part of that is now we're treating you at that cellular level as opposed to just giving drugs broadly and just hoping it works for you and then changing it if it doesn't. So instead of kind of a guess and check type of drug distribution, now we can be very precise in who a drug we think will work for them and what it won't work. And then as this evolves, you can think of things that now you have drug interactions, multiple drugs. So a lot of the people are not just on one drug, they're on 1, 2, 3, or 4. And you can't, right now the data isn't strong enough to do those kind of what they call polypharmacy types of approaches where you're looking at multiple drugs. So that's another place where we think there'll be impact on the precision medicine side, is not just one drug, but if you have a cocktail of drugs, what's going to happen?
Interesting. I think I remember like a couple of years back, I had a conversation with a bunch of sort of pharmacy or pharmaceutical executives in Boston Circle, and I think it was during Obama time, and there was, I think, a mandate from I think healthcare.gov around sort of transliterate or sort of creating an ontology in which all the pharmaceutical companies can share their sort of analysis on the research. So is that a reality now from your vantage point, or like how or are sort of you guys and pharmaceutical companies, do you have like some data sharing going on right now, or it's still in its infancy? We'll resume after a short break. This part of the podcast is brought to you by First Friday Fair, fastest AI-powered way to find your next opportunity. Check out the website firstfridayfair.tao.ai and find your next dream job. Let's get back to the podcast.
I say it's uneven. There's definitely stuff going on. So there's like a healthcare system. Like we work a little bit with healthcare, with pharmaceutical companies for individual drug trials, clinical trials. But as far as the data sharing aspect of that, there are some fairly large consortiums of people, so even through the NIH, through what they call clinical trials, clinical translational science awards, where they're bringing different like-minded institutions and putting the data together and think of a federated model. So you keep the identified data within your firewall, but you give like a catalog to a central company. And that company is the kind of the cataloger. So if a clinical or a pharmaceutical company wants to come in and say, hey, do you have a population that, is this age, of this ethnicity, maybe has this type of condition and is on this type of, or maybe has these type of lab values, we would like to be able to find those people and run a trial on a drug that we have in our pipeline. And those types of things are going on. And in a place like Inova, where we're in DC, we have a very diverse population, and it becomes very attractive for those pharmaceutical companies to go to one or two players instead of having to wait to accrue the right number of patients for their trials.
Interesting. And I think you also talked about biobanking in your pitch earlier. So what exactly is biobanking, if you can walk us through that?
So biobanking is, think of tissue inventory. So, the example I'll have is with the Cancer Genome Atlas. We were a bank, so think of very, very cold freezers, think negative 80 degrees, because tissue has to be stored so cold so it doesn't degrade. And it's not just tissue, it's blood, it's saliva, it's anything that you think of, any of the most disgusting things that come out of your body, they're banking it. And they want to know that, not only do they want to bank it, but they want to know a little bit about who you are, what your context was. Were you healthy? Were you diseased? So for example, in cancer, if you had a melanoma, they would take that off your skin, they'd freeze it, flash freeze it, put it in a vial, and they'd ship it on. And they'd say, and then they have a pathologist who would look at that and say, well, that person has, a stage 2 melanoma. And then we would track these particular phenotypic things about you. And that would be a bank. So just like you have a big vault with money in it, now we have a big vault with different specimens that are more valuable because we know things about them. And so if you can get enough of them and you see kind of a progression, so now you can see the people that are doing well with their cancer treatments or people who don't do well. And now you can start to aggregate them and take those specimens out of that bank, unfreeze them, and then see if you want to do particular types of biological tests against them. So genetics is the big one right now. So think whole genome sequencing, or maybe sequencing a specific gene that they think of as of interest. Things they call epigenetics, which are things above genetics. There's all kinds of, think of it almost like an onion. They started with genetics and they started to peel it out and say, well, there's actually more than genetics. And this data layer, so the data part of this is you have to understand, when the sample went in, who was attached to, how did they freeze it? So these are materials that are very, very finicky. So you have to store them in the right way. You can't take them out and thaw them and then put them back and expect them to be the same as they were, because they degrade. So this becomes a big business where these things are very valuable, and the more information you have on them, the more valuable they are to other hospital systems, to research institutes, and as you mentioned, pharmaceutical companies, because they become very rare if you see a rare disease or a collection of people who they think a target would be of interest. And so in cancer, we had, I think, 27 different cancers represented. And then we were the facility that would not only collect them and store them and track them, but we'd also be the ones that distributed them. So this then thinks of UPS. We were the UPS of and these things are really small. Think vials, very, very small, barcodes that had to be very procured, because you can't put barcodes on things that are negative 80 degrees. That you can get them at Staples. So this is actually very expensive as well. And there's places around the world that do this for a business. And again, we do this at our facility. There's a lot of hospitals. Mayo Clinic has very big ones. I mean, think robotics, think automation. I mean, there's all kinds of things that are happening now, and that data becomes very valuable, but then it also becomes very large and very disparate, because now you're doing different reactions and things that are microscopic. And the petabytes of data that we store are coming off data that size. And so just moving that around becomes cumbersome. So, we're kind of delving into the deepness of this, but from a data officer perspective, you have to understand all the nuances to the biobanking business, because that's what generates these larger files. Those larger files have to go to scientists. They have to understand the context in order to do their research in any way that's going to be valuable and timely, because a lot of them have limited funds, limited time to get their work done.
Interesting. And thank you so much for walking us through that. I think that's really, really informative for our listeners and viewers. So in your background, I think one thing that really was fascinating to me was, as you said, you're from accountant, business background, getting into the data science in healthcare. What is the difference? Like, how has been your journey from the perception wise? Like, how is healthcare data in healthcare industry vis-a-vis your previous experiences? We'll resume after a short break. This part of the podcast is brought to you by First Friday Fair, fastest AI-powered way to find your next opportunity. Check out the website firstfridayfair.tao.ai and find your next dream job. Let's get back to the podcast.
The healthcare industry, life sciences, was very archaic in that a lot of the things that businesses were kind of taking for granted, healthcare just wasn't doing yet. Or they were doing it in bulk and they were just doing it to keep the lights on. So IT and healthcare systems is very defensive, right? They want to protect things. They want to keep the lights running. They want patients to stay safe and secure, and they have a valid reason to do that. I mean, I've been a patient, my wife's been a patient. We want them to be as secure as possible to keep things running. And in the research side of things, that can be the opposite. You want to go fast. You want to, manipulate data pretty quickly. You don't want to wait 6 months to procure a system when your grant is accruing dollars. So, the research side of things tends to want to go quickly, where the general healthcare wants to go a little bit more methodically. And so where we came in is we're kind of a hybrid. We want to be in the middle of that, but we have to understand and empathize with both sides, right? We have to be kind of that blended. We want to go securely, protect our privacy, but then we also want to iterate, and we will break things, and we have to expect we're going to break things on the big data side. So how do we empathize with both sides and make the systems, the processes work? And in the business side, I think they were a lot more in that dev, test, prod type of areas, where in research it was all dev, right? There was no production. They didn't care that they wrote a piece of code and it broke and it bogged down systems. Like, well, patients aren't impacted. We didn't have redundancy. I mean, if something broke down, you had to wait for that thing to reboot. And some of these computers are not like a Windows and Macs. These things take hours and hours. These are big computers with multiple clusters and all kinds of direct attached storage that are very complicated. Formula One cars would be my very, very tuned. So coming into that area and trying to take these best practice things that were happening in business to a research environment is always met with a little bit of, why? What does that do for me? And so that's where, we've come in, and it takes a little while to educate. So we educate them on that side. And the great thing about a lot of these places, they educate you on the biology. Like if for people who are like, well, I'd like to get into this industry, if you like biology and you like, there's no greater place to be, because a lot of these people are researchers, they're professors. They actually love to talk about it. They love to get on a whiteboard at 6 o'clock on a Tuesday and really knock it out with you, because if you're in the right mindset, you're going to learn a hell of a lot from them, and they're going to learn a lot from you too. And it's a very symbiotic relationship.
Interesting. And so from I think one other thing that was really fascinating about your journey had been sort of you were sort of installed in a process when there's no process, and say, hey, now let's create this department, let's create this practice, and you did that. So what are some of the commonalities or some of the best practices that you have extracted that you could share that has helped you structure sort of these departments or structure these sort of practices? What are some of the things that you can share?
I mean, the first thing is, again, learning the business. I mean, you can't build a team if you don't understand the business. And if you've seen my history, I get into a lot of things that I don't know the business that well. So it's roll up your sleeves and get dirty. It is getting in there and understanding the business and the data that they're producing, and then asking a lot of questions. So being very curious, empathizing, and then finding people that are like that, right? Your first couple hires, you have to, build that into the DNA of your team. I've recruited a lot of people outside of the industry, because I also like diverse teams. People have different perspectives, because you get people that are already in healthcare and they already think defensively, then it becomes very hard to be offensive. And if you hire people that are on the research side that like to break things, then it becomes really hard to, get those methodologies. So I like to diversify that. So it's not just about a skill set. It's actually looking at the team you want to build, which should have a little bit of both. And then the very first couple, you get a little bit more senior people, because they're going to have to run on their own. If your hands dirty, you can't do the strategy, and you can't do the hand-to-hand combat all the time. You're almost coming up and down. So you have to find people that like that too, that can multitask, or they're almost kind of, I'm a quiet, calm person. Like under the surface, my legs are going like this really fast, but on the surface, I'm not. Or on the surface I am, but on the bottom I'm not. I'm constantly churning. So finding people that, are in that same kind of mentality, where they can inspire confidence, even though they question maybe even their sanity at times. And then building that into a team. And so as you onboard more people, you then looking at, hey, it's like a Kanban board. You're kind of looking at, hey, what's next? What's happening over and over again? And what skill set could help do that? What skill set could come in and help us document, automate, move this thing faster? And both from a contractor to an FTE, maybe it's a consultant or someone you have in your portfolio that hey, they're great at infrastructure. They've worked it here. Let's bring them in. Let's talk to them, because we were mentioning before, nobody knows it all, and nobody will ever know it all. So if you have that mindset of, hey, I need to have a team here. I need to have someone who I can consult with to give me some sanity. If I'm knee deep in it, sometimes my blinders are on. I think that also happens very early for me. And again, bring in some people that I would say document a lot of documentation early, understanding, doing a lot of interviewing, and then trying to organize that in a way. And I haven't found the perfect way to organize all your thoughts. Like I'm an Evernote type of person, and I try to tag things so that I can go back and search, because you can't remember it all. But a lot of it is, spending a lot of time early on documentation and trying to aggregate things that are happening again over and over again, so that those are the things you attack first, and those are the people that you want to come in and help first.
Interesting. I think that's fascinating. So one more thing that I can recall from some of the conversation I had from folks from health and pharmaceutical industry in data leadership is sort of, I think, somewhat the constant frustration around the regulation, right? So as a data scientist, you can do a lot as a data sort of, if you are running a sort of a center of excellence for data, you can get a lot of insights and do a lot of fun stuff. But because of regulations, and I think you pointed out some of it, that the systems were archaic and sort of they're not talking to each other and all that. How has been your journey? Like, what has been your experience and appreciation about sort of these extremely secure infrastructure that you have to work, sort of negotiate to get your data, to get the analysis going that probably scientists want or researchers want for their execution? What has been your sort of experience?
So this is very interesting, because we're going through this even now, right? So it's a lot of people skills. Like, as bad as this sounds, like we always talk about automation, we talk about technical details. A lot of things that I've seen is that you have to find the people that are controlling, the access, and understanding their needs, their assessments. How can you, talk their language? And then again, we're in the middle. So we're kind of the middle between IT and we're the traditional IT, and we're in the middle of the research side, and they want to go fast and one wants to go slow. So a lot of this is relationship building, understanding what their goals and assets are. How can we enable them? Because if not, they're going to get the direct researcher going to them, right? On our side, the direct scientists or the direct software development teams are going to be coming in from the outside wanting to hit IT. And we want to be that trusted intermediary to understand their privacy concerns. Do they understand or not understand what we're trying to do? How can we articulate that in a way that's very consistent? Do they have a data governance process around this stuff? And again, coming from where we're at, Inova didn't have a research governance system. They have clinical data governance, but they don't have research data governance. It's a different animal. And so a lot of this is education, right? I think the term we use a lot is data literacy, right? We want to become literate as an organization around what we can and can't do, because I don't want to get in trouble. I don't want to be in the front of Wall Street Journal because genetics got out. Nobody there does. So how do we come into this way, and then that architecture and that process can then flow from there. So if they're, you'll see that a lot of this is based on the environment that we're in, which is if there's a data breach at Target, all of a sudden people clam up. There's been some local things in DC where, we're in the government space, we're around a lot of cyber companies, and they come in and they, again, they just want checklists. Well, the checklist is fine, but if you don't know the reason why you're doing the checklist, you might not realize why you're checking things on or off. So again, from our perspective, we want to know, what they want us to do, how we can do it, how can we become a trusted partner. And then once we get to that trusted partnership, how do we make things go a little bit faster, incrementally? Because this is not going to be all of a sudden everything's going to open up and everybody's going to be happy and high-fiving. We want to take those incremental understanding, let's do a couple things, and then let's work our way back. And as there's more and more data and there's more and more ways to, let's say, anonymize or de-identify it, there's also now more ways to re-identify. And so here there's a lot of discussion around, you can anonymize a data set about a patient, right? But if there's a public breach, can we now re-identify them, even if you've done best practice HIPAA de-identification? And I think you're going to ask me eventually about a book that I was reading. And so there's a new book that came out that I'm knee deep in, that I'm enamored with, because this has been in healthcare. This has been going on for a long time, but nobody really talks about it, because who would want to know that they're behind the scenes trading? It's de-identified, but it's still information about you and me and the people who come into health systems. So it is a bottleneck and it is a concern. And on the research side, they're aware of it. But again, we have to be, in our perspective, we need to be trusted advisors in the middle to get some of that data out and useful for our researchers.
Interesting. And I think you talked about a very important sort of keyword that's extremely relevant for folks who are in regulated industry. I think data literacy, right? So educating or empowering sort of other folks to understand why you need what you need and sort of how you need what you need. So what are some of the best practices that you have gathered in your experience sort of in educating and empowering other workers and understanding that why you need whatever you need and creating those data governance model, and what are some of the things that you could share?
So what we typically do is we actually have standing meetings. We start with standing meetings, right? You have to have a cadence. Like if you tell them one time and then they're going to lose it if they don't hear it at least a second or a third time. So, we start with who's giving us the data requests. So if that's a clinical team, if that's a bioinformatics team, we have regular meetings with them and we start to ask them for at least a write-up of why they want data. And that's where it starts, because when you're starting early, you don't know all the different things you want to ask. It's tough to create a process that's perfect because God knows that it'll never be perfect. So we start very basic. And again, it's kind of this Kanban-ish first in, first out. You ask for that request, what are you asking for? Is there PHI in it? Is our very first question always, are you asking for practical information? If it is, then we have a route which goes up under compliant. If it's non-PHI, then we can get it done faster. And so we stratify very early. But then on the literacy side, then we start to ask different questions. And because typically what happens in these, I would call it very white glove, very custom data pulls that they want, you have to understand how they talk about their data. So do you have a common vernacular? Because the way I talk about it might be very technical and very sterile, and I don't know the business that well, where they might be talking about it in a very specific way. So being face-to-face and finding ways that you can actually be in a room where you can visualize the data with them has also been extremely helpful, because then they see something tangible. If you're just exchanging emails with Excel spreadsheets or CSV files or whatever in there, or even a link to a Tableau type of visualization, it's hard for you to get any momentum in that very much way. We need interaction here. So again, having a cadence, having a meeting regularly, and starting to go through the requests, asking the same questions over and over again, so they get into a repeating pattern of, I know they're going to ask this now, so maybe the next time they don't ask it, and we can get a step farther, which is okay. Maybe I don't even ask that question anymore. And then again, back to the repeating. If you start getting the same questions over and over again, can I automate those types of things? Can I automate those types of queries? Can I automate that type of visualization for them? Can I do some self-service? Again, we're just trying to make headroads so that we have a better time spent. We want the cost of our time, their time, which is very valuable, to be done in things that are moving us forward, as opposed to rehashing things that have already been asked and already been done. But you can only do that by being face-to-face and being repetitive, which is not that sexy, but sometimes that's what you have to do.
Interesting. And I think, and you're pretty connected in this field of data science in health space. And I think from your vantage point, how has been culture of these organizations responding to sort of folks like you? What has been your observation? Like, are they friendlier now than they used to? Are they more collaborative now? Like, what has been your experience in dealing with sort of the business folks and in sort of in getting the data out and then sort of creating this silos? Like, what has been your experience?
It definitely comes down again to personalities. But in your organization, you get a reputation of a success. Like, hey, that person is good to work with. They're realistic. They talk to you. You tend to get you tend to get better responses early. But versus when you first come in, and they're siloed. They're tight with their data. They want to know why. They might throw things like, I have regulations, and then you ask them for the regulations, and then they say, well, it's because my boss or my PI doesn't want this, or the CIO says I can't do this. And then you have to go through those hoops in a very transparent way. What I found, as long as you're open and honest with people, they tend to be more receptive to that. But there also is those people that you just can't get past. And there's also that time where you have an opportunity cost with your own internal time. And so then, how much time do you spend on that, and it comes down to the priority of it, the way this might be seen through your organization. So there's times when you have to go up to your reporting line to get things done, and there's times when you just get them on a call again, get somebody in the room. The emails to me just don't work when you're trying to have that time of response. And it's difficult sometimes if you're co-located or you're not always there. These people are busy. So sometimes what I've seen is getting on the calendar, getting very good with somebody's admin. So if you know their administrator and you can give her a coffee or some cookies, she can get you on the schedule. Sometimes it's those low, again, we're having a technical type of discussion here, but what you can see, there's a lot of nuance to getting the things you want done in an enterprise level like this, which sometimes is the soft skills of that. And communication is very big for our team, because this is what we promote to our entire team. Like you're technically savvy, you can do it. I know you can do it, but you can't demand things. You have to have some kind of savvy to asking for the right things so that we can get our work done.
Interesting. And I think from your vantage point, and I'm not talking specific about your personal interaction, but what are some of the challenges that a data science leader faces in an organization, in say healthcare space or sort of bioinformatics? Like what are some of the challenges that you see that the data science leader faces?
I say the one that always hits me, the very first thing, is expectations. So there's this part of people that think this is magic, and that on the executive level they'll see the marketing, they'll see think of and I've done these presentations to our executives, and it's literally think of the yellow brick road, and they think the Emerald Palace is at the end of this. It's very easy. All you got to do is put it in Watson, and this thing's going to spit out something magical for you. And in healthcare, I think in anything it's really difficult, and I think in healthcare it's become extra difficult because the data is uneven, it's incomplete, it's not as good as I think sometimes the executives think it is. And a lot of this is education back to literacy, of saying, hey, we're spending about 80% of our time just getting the data to the people who need it. We need to make some fundamental infrastructure changes in order to make that now flip. So instead of 80% of the time of just munging and wrangling and all the terms that you probably have heard everybody talk to, how do we do that in a way that now we can flip it? And so now we're never going to get away from having to wrangle data. It's not going to happen anytime soon. The machines aren't going to be that smart, especially when it's the first time they've seen this stuff. And that's the way it is in the genetics. I mean, there's some data we've never seen before. We need to be better with the low hanging fruit. And so the education of them to say, we have to have the infrastructure, we have to have the teams. This is going to be a significant cost to get you up above the ground, but then think of it as an investment in the future. And in healthcare, there's going to be a lot of change the way we're reimbursed. There's going to be a lot of change in the way that healthcare is going to be paid. And so a lot of this is just educating them on what this is truly going to take, and it's not magic.
Interesting. And what are some of the things that you say are pleasantly surprised with when you are dealing with sort of this leadership, that they just get it somehow? Like, what are some of the things that you can share?
I think they're extremely passionate about things. They once you get them on your side, they are extremely dedicated, hardworking, and they have great ideas. And so that's the other thing that's, I think, magical about this time, is that you have different perspectives. And if you have the right team on the infrastructure side and on the data science side, and you can team them with the business side and these amazing clinicians and these amazing scientists, truly magic does happen. But sometimes it's lightning in a bottle, and it's doing that and repeating it that I think is tough. When there's the grants and the researchers, they're transient. They move on to another project. So how do you create an ecosystem where this is really the norm and not that lightning in a bottle? But to me, I've seen it happen. I've seen it happen in the cancer researcher. I've seen it happen at Inova, and that's what brings us back to work every day, looking for that and seeing that happen. So I think it's a very exciting time.
Interesting. And what are sort of some of the big opportunities that you see, or some that for anyone trying to enter into sort of health space or health data space? What are some of the big opportunities you think that still exist and still sort of we can explore?
Well, I think there's so many targets in healthcare right now. So I'll give you some examples of things that we've seen that would be enticing for just pretty much anybody. So think of the Alexa type apps. So think of things where you're doing voice recognition and you're able to put that into a format that is in a logical way, so that we can mine that information instead of having like transcription or it's like free text notes. I mean, there's a lot of work going on in NLP, which is great, but you're actually too far upstream. I think you should really get to the source of it, which is let's make these interactive kind of discussions that doctors and patients are having, and use this great technology and put that in place, and then have all this machine learning on the back end of that to clean up the text, to put it into a format that then people and the machines can then use to aggregate and to make some really important kind of associations that we wouldn't necessarily know because it's embedded in digital, but it's all over the place. And so I think we've seen that. I think another area is what I would call image recognition. Now, this is similar to the stuff you'll see with like self-driving cars, but pathology images on cells in cancer, looking at how aggressive they are, and then finding what the impact of certain drugs are over time, and seeing the impact of the drug on a particular person. But you can now look at a slide and say how aggressive it is. This is the type of drug that will work for that cell, and you can have that all automated. So right now a lot of the pathology work is visual, and it's on these experts, and that's great. But now if we can have the pathologists train these image recognition tools, the pathologists can now kind of move their focus instead of eyeballing these things all day. Now they can get into the creative side of things, which is the rare disease, how they treat, and finding more ways to enrich that information, as opposed to just kind of blindly going, not say blindly going through, but doing the same things over and over again, which is kind of mind-numbing. I'd like to be able to, I think the machines in our world and this data is going to help us take away the mundane things and get us moving forward. So we're not doing so many of those things. We're doing the things that I think are going to push us forward, because right now the humans are the ones that are going to move us forward, not the machines. The machines are going to enable us, but they're not going to solve it. So I think those are two areas that I see right now in healthcare that are exploding and need a lot of talent on the data side to help.
Interesting. And say if I'm a health system nowadays and I'm looking for, say, someone to lead my data science practice, like what would you say are the ingredients of a good leader that I should be looking out for? Like what?
Well, I think that somebody, I'm going to go with the soft skills first, and then because the technical side, I think they're well written of what you can go out there and find. In a healthcare space, you're definitely going to have to be a good communicator. You're definitely going to have to be able to learn quickly. And really, you're going to be talking to some people that know their PhDs or MDs have been around for quite a while. They know their business very well. They're going to challenge you. They're going to challenge you because they don't know your world. And so you're going to have to be able to communicate. You're going to have to be able to get requirements. You're going to have to be able to iterate and come back. And so rapid learning, people who can learn rapidly, that have shown that they can be in different industries and pick things up. Because I would tell you, there's a talent pool that's very limited right now for that. And so you want to stick yourself out. If you have great skills in Python, or you have great skills in R, that might not be the way that you'll still stick out to everybody else. It might be the fact that you can come in, you can communicate, you can take results, and you can show them, and you can tell people and understand why those results happen. So it's not about doing your data, putting it into an algorithm, shooting it out and saying, hey, look at what I found. You have to be able to explain it, because they're going to nitpick everything that you do, and they're going to challenge it. And the other thing that we've seen a lot in healthcare with these apps or these algorithms is that if you can't explain them, if they're kind of black box. They have the scientists have a hard time thinking that that's the answer. They really want to know why. They don't trust anything. And so coming in this space, if you're a person that's really good at understanding and communicating why that happened, and then even question your own results and getting really good at, how sensitive is that analysis that I did? What were my assumptions? Did I make the right assumptions? Can I ask a particular person, hey, I did this, is this right? So being very, I would say, humble at first, because you're going to get humbled if you're in this for a while, because there is so much to learn. So those would be the things I would look out for.
Interesting. And on that same, if we stay on the same hypothetical, so if, say, someone comes in and joins that role, what are, say, some of the initial things that you would recommend this particular gentleman or gentlewoman to sort of explore when it comes to creating this data science practice? Like, what are some of the things that you would suggest as a tactical steps that they could take?
Technical steps. So I think a lot of this is getting their hands dirty and looking at the data, how it actually comes into the system. Understanding the context first, because if you get it at the end, especially in our world, there's a lot of things that happen to that data before it gets into the hands of our groups. So it's actually going through and understanding how the data came in. Did it come in through the EMR? Did it go through a biobank? And what are all the things that happened to it? So it is really getting dirty with the data. Again, coming in and out of getting dirty, and then coming up for air and asking questions, and going back and learning more about the business. And then it's also about the tools. So a lot of this is having standardized tools, being very good at documenting, what you're doing, your code. We're and I don't know if you guys have interviewed a lot of people on like data science platforms. Having these ways that a lot of us are really keen on data lineage and reproducibility. And because our data is coming from various places, sometimes it's very hard to put that into a consistent view of, did it come in through the cloud and sucked down and put on a machine and had some stuff happen to it, versus did it come from an app and then people manipulated it and then there was some massaging to it. So, that's a very hard thing for us to do and to figure out. Once we get it, we want to have it in one ecosystem so we can track whatever all people are doing to it. And of course, then it comes down to even from the protection side. We have to know what people are doing and what they're touching, and are they moving in places that they should be. So, but we like scientists who, that's a kind of their mindset. They understand that, you can't just hack away at it and then leave it go, or not have something. Even when you fail or you don't get somewhere, we want to know that, because then we can make our systems better. We can make our knowledge better. And if you do clean up data, we want to know you cleaned it up, because maybe there's a root cause to that we could clean up later.
Interesting. Fascinating, by the way. And thank you so much for walking us through this. It's really, really useful for anyone venturing into the data science leadership roles and in healthcare space. So other thing that I definitely am curious about to learn from you is the team dynamics, or say if on the same hypothetical, what are some of the team best practices that you would suggest to this particular sort of executive? What are some of the team best practices that you have gathered around how to build a team or put together a team that is serving this sort of this narrative of data could be supporting a scientist, and sort of data could be sitting on any silos? Whatever you can share around the team.
Right. So, we still struggle with this. This is still an area where, when you look at the full data life cycle, the type of talent you need to go from just acquiring it all the way to actually putting it back in the healthcare system, it's quite a range. And so we found out we've had some really good people, again, back, it's a team concept. We need the whole full thing. But I would say that one of the biggest lessons learned we have is to make sure the team knows the entire, that whole entire lineage and who does what, right? A lot of people want to try to do end-to-end themselves. A lot of people will want to, skip a step. And so a lot of this is, again, building the team concept. Here's all the things we want to do, and here's why. And so even if you don't do, the low level blocking and tackling on the clinical data, but you're going to use it, you kind of have to understand who does it and why they do it that way. Even if you're just taking it at the end, because a lot of times these teams are interacting. And if you can have them understand that full, it kind of eliminates a lot of those either false assumptions that are made at the end, or even the way that the individuals rub each other the wrong way on the way they do things. So, and one of the things that we're concentrating on is actually having a kind of a bridge team. So you have these very, very sophisticated people that might be using open source code that they got off, let's say they were working with a researcher at MIT, and they have some open source code. But if you want to apply that to a Hadoop cluster, it doesn't automatically magically happen. So then we need the engineers to go in and say, well, now how does that code, what are all the compiled code? What do we need to do? Do we have the right versions? All these kind of ways that the scientists will talk that the infrastructure architecture people don't necessarily understand. So bringing those teams together to understand both sides of what we're trying to do. And what I'm looking at is even a bridge team that is like that. So you have your, again, I would call them machine learning engineers, and some of your more sophisticated software development teams interfacing with the infrastructure side, the people that have to keep the thing running and redundant, resilient, and have a best practice around that kind of, taking code that was brought in from the outside and productionizing it, or not productionizing it, and isolating to a Docker and to keep that off the grid. Not sure. So almost like risk profiling. And when you have dozens of scientists doing this, making that into a scalable, cohesive unit is something that we struggled with.
Interesting. And so with that, we are almost at the tail end of the conversation. And Aaron, thank you so much for walking us through this amazing treasure trove of good information. That's really useful for us. So let's talk about you for a few minutes. So in your journey so far, what are some of the tenets that has helped you stay successful or sane through this transformation and through going through this extremely rapidly evolving fields?
Well, I think a lot of this is, that mentality of looking at this in a simple way. So a lot of the stuff that we do is very technical. It's very detail oriented, and you get yourself wrapped up in trying to be perfect. And very early on, I think that's the way I was trying to make this all perfect and everything was tidy, and really spent a lot of time on that last 5%. But what I found out is that a lot of times you spend 80% of your time on that last 5% to get it perfect when you're going to probably change it anyway. Or somebody's going to critique it. So it's really trying to get that first 80% done as fast as possible, not perfect, and then building the team around how to really make you embrace your imperfections, to make you more well-rounded and not try to be perfect and spend all this time and then get frustrated when people review it and you're like, oh no, that's not perfect. So really looking at things that I can do well, simplistically, and then bringing others in to help, and really trying to take those, look at my career, look at myself and say, well, maybe that's not what I like to do. Maybe I like to do, but maybe I'm not good at it. And being very realistic of what, my talents can bring to the table. And at the end of the day, when you look at yourself, you have a utility, right? You have so many years that you can work. There's so many hours that you want to work and you want to have a life. So how can you build your life and your work and your productivity around getting the most out of your 8 hours or 10 hours, whatever many hours you do a day? And so that's really what I try to do more recently, because like you said, you can go mad. You need a lot of help if you're going to be, you're technical and you got your headphones on, you're knee deep in it. Sometimes coming out of that vacuum, having to do that in a way that keeps you fresh and keeps you motivated. And then again, from the team perspective, keeps you, a member of that team, a valid member of that team. So I've learned that, just keep things fairly, be rational with your time, be cautious with your time, and then rely on others and build a really nice support system.
Interesting. And thank you, Aaron, on that. And to our listener and viewers, I do want to say that how true whatever Aaron is saying is. It is. Today is, I think it's Sunday evening, and we can see that you are extremely patient on Sunday evening and sort of walking me through this barrage of interesting questions. So appreciate definitely whatever you're saying and whatever you're standing for. I do appreciate that. So one more thing I ask our our guest is some of the books that they can share with our viewers and listeners. Like, do you have any recommendations that you like to share?
Yeah, so I would say two. One actually kind of piggybacks on that last one. It's called Smart Cuts. And I think I wrote down over here, I think who that was written by. If I give out a book to some of my leaders, it's that one. And it's all about, trying to, why do certain people go faster and go up the hill faster? Why it was, the anecdote was about the president. So the presidents are usually younger than the senior senators. It's because they know how to kind of move throughout the organization. Again, being very simplistic, finding the right people, being connected. And so that book, I think, it's not very long. It's a lot of stories, but I think it's a very interesting book about how to, navigate a career. And the other one that I like, it's by Daniel Pink, and it's called When. And it's all about, for people who like productivity and like to get the best out of themselves. He wrote a book about almost like more biorhythms. And so there's certain times of the day when you're more productive. There's certain times of the day when you're not productive and you kind of take into a trowel. And there's times when you're more creative. And so this book goes through that and really gives good tangible examples. And I've started to use it and I've noticed in a more calmness. Like, I don't know if you can see this, I have a Fitbit ring. And so this actually, some of the tech that I like is tech that's actionable for health. This is like a Fitbit, but it's on your hand, and it actually in the morning it'll tell you if you're ready for the day. And so it tracks you over time. And so now that I've been doing that, my heart rate is going down, my sleep is getting better. And so it's a very interesting concept that I, again, as a young person, it was like, I'm going to go as hard as I can. I'm going to work as hard. I don't care. And then as you get older, you're like, I can't sustain that. So there's got to be some hacks that you can do. And those two books, I think, are very good at, looking at the big picture as you're going through career, and also get your day to day and trying to get the best out of your days.
Beautiful. And with that, we are at the end of the conversation. And so one thing that as a closing remark, what would you like to share with our viewers and listeners? If one thing they want to take away from our sort of this long conversation, what would that be? What would you say to those?
I say that, one of the things that changed in my career was when I moved from, the business side to this more research healthcare side. It was that why. So that's the other thing, really trying to understand the why of why you do things. And I think that is a very big help, especially when you get into situations where you are struggling and it is a Sunday night and you don't want to go to work the next day. What's going to get you up in the morning? I would say, think about that why for you. And that's also how you're going to learn, because if you want to learn some things that'll get you over the edge is that why. So for me, it's healthcare, it's helping people, but for you, everybody's going to be a little bit different. So find that why.
Interesting. With that, Aaron, thank you so much for being extremely generous with your time, walking us through some of the, again, very interesting topics in a very edible way. I do appreciate your time on that, and you're always welcome back on the podcast. Wish you nothing but success in your journey, and thank you so much.
No, thank you, and best of luck to everyone who's listening.
I thought I was sick of home, but actually I was homesick. Never really knew that I would have to grow up so quick. I'm so uncomfortable, don't know anybody here. Just a couple dudes that I met once, that's it. And I go into the booth feeling nervous. Got butterflies in my stomach like I'm so worthless. Is the mic on? I don't know how to work this. Inside I'm breaking down, I hope I'm not up on the